Well, I see a bunch of wavy baseline. And then you see things like maybe here in lead 2, you see something that sort of looks like P wave, but you just don't see things that are consistent. And you don't see that the P wave looks the same on every beat. Quote, P wave looks the same on every beat. So this is AFib. And oh, that's Gabby's message. So that's AFib. Let's go to case 2. 61-year-old male comes to the ED with palpitations. Heart rate is 155 beats per minute. Blood pressure is normal. And this is his ECG. And so we are going to do the, what does this ECG show? So is it sinus tach, AFib, a flutter, atrial tachycardia, or is this artifact?
All right, everybody's doing great. We're getting our votes in here. Give folks another 10 seconds or so. Okay, perfect. I'm going to go ahead and end the poll and I'll share your results.
Great. So 54% got this one right. This is atrial flutter. Now, what I'll say is it's tough, right? It's tough to see this. You have this, number one, I gave you a single lead and I told you don't do that. One thing that makes it tough, but when you look here at the 12 lead, it is tough to guess this and get it right. You have a regular, because you have your calipers, your regular narrow complex tachycardia. So you're going to be thinking, all right, regular narrow complex tachycardia, sinus tachycardia is the most common one, but why would does it make sense with the presentation for someone to have a regular narrow complex tachycardia? Like, should this patient be having that or not, and have it be sinus? And then you look at this, and for me, if I have someone who's coming in and I see downsloping ST depressions in the inferior leads, so in leads 2, 3 is a little noisy here in AVF, I see this and I'm like, gosh, that sort of looks like a flutter wave to me, but I only see one, I don't see the second one. Is it buried in the QRS? It's a little tough to tell, but if I see this downsloping ST depression, I'm at least thinking, all right, could there be flutter waves buried in that? But you don't know for sure, and so you got to do something about it. Sometimes it is easier to see atrial flutter. I think if I had given you this EKG, we would have had a higher answer rate to that, because when you have a slower rate, here it is, you have a 4-to-1 flutter, and you look in lead 3, let's say, and you have this negative sawtooth deflection in the inferior leads, and you can see it's constantly going, and the QRS complexes are marching on top of it, is what it feels. And this is a much easier thing to see, but not every patient is going to come in having an EKG where it's easy to see. Even though we ask them to, sometimes you have to try and do things to try and slow the heart rate down or have them naturally slow it down. For whatever reason, flutter tends to come in a little bit more commonly in even numbers, meaning you'll get a 2-to-1 or you'll get 4-to-1 or 6-to-1. It's less common that you'll get 3 or 5-to-1, and it's less common that it'll be alternating with a variable conduction pattern of like 2-to-1, 4-to-1, 3-to-1, 5-to-1, something like that. Sometimes you'll see an ECG like this, and if you look, let's say in lead 2 here, you get these really big, quote, P waves, and you say, wow, that looks like an atrial tachycardia or a flutter, because you see such big atrial activity here, but you don't see the same pattern of that, quote, P wave on every beat. So especially if we look here in V1, you get the really, really big ones here, and then it sort of gets smaller, and then it gets more flat here. So this is still AFib. Sometimes we'll call it atrial flubber, but really it's AFib is what this is. So the management, you're called for someone like this. First question is always with every arrhythmia, is the patient hemodynamically stable? All right, so is their blood pressure okay? Are they maintaining okay? Do they have hypotension? Do they have acute heart failure? Is there ischemia or angina concerns? And the hemodynamic stability does not let you make the diagnosis. You can have people who have SVT or AFib who have a blood pressure of 60/40, and you can have people who have monomorphic VT who are hypertensive. So don't let your hemodynamics help guide you. But that's the first question you're going to ask is, are they hemodynamically stable? Because if they're not, then you have to cardiovert them. If someone is stable, what do you do? So in the hospital setting, most patients will cardiovert within 24 hours. So you may not need to do anything, even though there's this sense of like, I have to do something because something changed and it's my job on call to do something. But that's not always true. So if you have someone who's going really fast or they have symptoms like mild to moderate symptoms, severe symptoms, cardiovert, but mild to moderate symptoms, then yeah, I would do something. But if it's someone who's not symptomatic, then and their heart rate is less than 110 beats per minute, I typically would sort of let it ride and see what happens. But really, I use that heart rate cutoff of about 110 to help figure out whether to do something or not. And please, please, please don't check a troponin just because someone went into an arrhythmia or just went into AFib. Check a troponin because they're having chest pain and you're concerned that there's an MI. But AFib in the hospital setting does not reflect an acute coronary syndrome, and please do not be checking a troponin mid-setting. So what are you going to do if you do want to do something? So depending on how fast they're going and what their AFib history is like, diltiazem is probably the most common thing you're going to use, probably just because you can give it IV and you can give it IV on the floor. They don't need to be in a unit for it. You can give them a bolus of anywhere between 5 to 20 milligrams IV, and then you can start a drip at 5 to 20 milligrams per hour. If you have any concerns about blood pressure, please be starting on the lower end of that. And usually with the drip, you're going to start on the lower end of that. So pretty commonly, I'll give a 20 milligram bolus, and then I'll do like 5 milligrams per hour, and then you can have it titrated for a heart rate effect. You can give a few doses of IV metoprolol instead, but the duration of action is not super long, and so you're not going to get a huge long-term effect. If you're going to use metoprolol, either you're using it in the setting of acute coronary syndrome, a real acute coronary syndrome or perceived, or you're using it as a bridge to giving them some sort of PO medication. And so for PO, you can use diltiazem. Oftentimes you'll be using diltiazem as you transition from a diltiazem drip to diltiazem PO. Verapamil, less common, but sometimes we'll use it. And the metoprolol, we use very commonly. Atenolol, digoxin probably doesn't have a huge effect. It takes a couple days to kick in, and we just don't use digoxin very much anymore because it just doesn't work quite as well. Rhythm control. So if you really think that someone needs to be converted back, then amiodarone. You'll use a lot of amiodarone anytime you're on a cardiology service. You'll be using amiodarone. So 150 milligrams IV bolus, and then you start a drip. It's between 0.5 and 1 mg per minute. And you really want to have the person have some sort of central line. So PICC line can be used for this, but any sort of central line can work. You can get this thrombophlebitis. This is one of my patients who had the amiodarone being given peripherally. Sometimes I will use flecainide, propafenone, or ibutylide. That's not something you should ever be doing. And even frankly, the cardiology service is usually calling EP if we're ever going to do something like this. So I saw a question from Anna: in patients with rapid rate over 110 but stable and without symptoms, do you need to bridge to PO, or can you just start with PO? That's great. It depends. If it's like 120, I will just give oral and just start with a PO medication. But if someone's going at 180 beats a minute and they're not feeling it, but they're going that fast, I'll do a drip. I don't have a hard cutoff number to say, but what I would say is, yeah, you can do orals if it's on the lower end of the rapid rates, and IVs if it's on the higher end. And again, if someone's really having symptoms, I'm going to be a little bit more likely to go with IV versus orals. Anticoagulation. So one of the things that we know is that there is an increased risk of stroke in the first 4 weeks after someone has had a cardioversion. And it does seem like that risk is higher with a cardioversion versus someone just naturally going back in and out on their own. So if you have someone who is in AFib for over 48 hours, regardless of what their CHA2 VASc score is, and we're not going to get into that, then they either need 3 weeks of continuous anticoagulation. Now, with the DOACs that we have nowadays, if you miss 1 dose or 2 doses, you're probably okay. But for warfarin, you want to have a documented therapeutic INR. Or you need to do a transesophageal echocardiogram to rule out a thrombus in the left atrium, and then you can anticoagulate. But either way, you need 4 weeks of anticoagulation afterwards. If you have someone who has been in AFib for over 48 hours, but you need to emergently cardiovert them, they're hypotensive for some reason, do what you got to do to save their life, cardiovert them, give them a heparin bolus, immediately or as soon as you can, and then anticoagulate for 4 weeks. If you have someone who's been in AFib for less than 48 hours, you may not need to anticoagulate them. So if you have someone who's got a CHA2 VAS score that's very low, who's been in it for 24 hours, you can just cardiovert them without anticoagulation. However, if you have someone who's higher risk, like they have mitral stenosis, like rheumatic mitral stenosis, if you have a CHA2 VAS of 7, or if you have hypertrophic cardiomyopathy, someone like that, you may say, look, even a short time window of 12 or 24 hours is concerning enough to me that I would want to anticoagulate this person.
Hey, Jordan, before you go on,
Yeah.
a question that tends to come up every year, so I'm going to just prompt it, is the question around DC cardioversion versus chemical cardioversion and anticoagulation. Do you mind speaking to that for 30 seconds?
Yeah, there's like the medical answer and there's the legal answer. The medical answer is there is still a risk of stroke associated with cardioversion with amiodarone. That's probably the one you guys are going to use. Ibutylite is the one that I will use sometimes. There is still a risk to it. The risk is probably lower compared to a external shock versus using amiodarone. That's sort of the medical answer. The legal answer is you have done an action which has led to the cardioversion of a patient. If they have a stroke, you would be considered liable. So what I typically say is, look, if you're going to have someone on amiodarone and it's been over 48 hours, you should be looking at doing anticoagulation. All right, sinus tach. So you've got a 30-year-old who's admitted with shortness of breath, heart rate is 175 beats a minute. Be worried about this patient. All right, anytime you have someone who's got sinus tachycardia, there's something going on. And here's a partial differential of it. This is by no means exhaustive. But anytime you have someone who has sinus tachycardia, be a little bit worried about it because there's something going on and you got to figure out what it is. In general, the treatment for sinus tachycardia is don't treat it. It's a secondary response to something going on. So try and treat whatever the underlying cause is. And the one situation where you would treat it would be in the setting of an acute MI, and then you would use a beta blocker like I do metoprolol in that setting. All right, case 3. So you have a 63-year-old male who's admitted with chest pain to 5 Northeast. While waiting for his chest test, he reports the abrupt onset of palpitations and mild chest discomfort to his nurse. His pulse is 150, his blood pressure is 132/88, and he has this ECG. And I'm going to give you 2 leads this time, not just 1. And so what are you going to do? You're going to cry? You're going to call your senior resident? You're going to give adenosine? You're going to give metoprolol? You're going to do all of the above?
For the record, I've cried before.
Oh, yeah. I cried several times when I was an intern. I am fine admitting that. It is a very tough year, and I do not envy you going through it, yet, except for the fact that you learn so much, and I never learned as much as I did as during my intern year.
All right. Let's give everyone just a few more seconds. Okay. Great. All right, I'm going to go ahead and call it. And here we go.
Okay.
A pretty even split there.
Everyone is right.
Yay, everyone's a winner.
Exactly. I know I say give adenosine, but you know what? Everyone, I would actually say I would give adenosine, but honestly, I think any or all are fine. You have a regular narrow complex tachycardia. It's a little concerning that you're having these ST depressions in the inferior leads and in the lateral leads. Here, 2, 3 in AVF, you have ST depression. You get it here in V4 to V6. It's sort of upsloping-ish here in V3. Oh gosh, my office has a motion sensor in it, and so if I don't move, it always turns off. All right. So we gave adenosine for this patient, and the number one thing is if you are going to do adenosine, absolutely please make sure that they are on similar sort of telemetry, or even more preferably that you were running a 12 lead with the rhythm strip going while you're giving the adenosine. I won't believe anything you tell me about what happened unless I can see it myself. So either have a 12 lead of it, or like have the telemetry going in some way and make sure it's saved. Like if they're in the ER, make sure they're printing paper out in some way so that so that we can see it at a later time. In this patient, we gave adenosine, and what you can see with those arrows there is P waves marching through. So he was actually in an atrial tachycardia, and it was going a 1-to-1 atrial tachycardia. But you could only unmask that and see that with the adenosine. You really couldn't see that because those P waves are either too small or buried when he was in his tachycardia. And then the arrhythmia kept going. And atrial tachycardias typically will not terminate with adenosine. They do occasionally, but not very commonly. So then he went back into his heart rate going faster, and then I think we gave him metoprolol or whatever it was. Sometimes you'll have someone like this who is in a different SVT, but again, it's a regular narrow complex tachycardia. One of the things that makes this EKG interesting and to help figure out what your diagnosis is that this person has what's called a pseudo R prime in V1. So it sort of looks like a bundle branch block, sort of looks like the bunny ears of a right bundle branch block. And that R prime is not there in sinus rhythm in this patient. And so when you see that, that's pretty suggestive of AV-nRT as the cause, because that's a P wave, and that P wave is so close to the QRS complex. So in V1, you can see there's the sort of looks like the a right bundle branch block, sort of looks like an R prime, but that's a P wave. You can also see in the inferior leads, like here in lead 2, you have this negative deflection. So this is AV-nRT. With someone like this, when you give this person adenosine, here it is on the left side, they're in their tachycardia. Looks a little different because this might probably be a different patient actually. And this time you don't see something marching through. Now the baseline is flat because you've terminated the tachycardia. AV-nRT, AVRT, you'll be able to terminate the tachycardia, and then very commonly you get a bunch of like ectopy in that time window, and you get the heart block and you get escape beats, and then they go back into sinus. If you are going to give someone adenosine, it's always good to prepare the patient ahead of time and just say, you're going to feel awful. Like you're going to feel like you're going to die, but then you're going to feel better within a few seconds. And depending on the situation, the patient may be like, that's fine. I don't mind feeling bad because I'm feeling bad already right now. But just to prepare the person ahead of time and just say, look, you're going to feel like you have a shortness of breath. You're going to feel like you have a chest heaviness. You may feel like you have a headache briefly. If you have someone who has SVT in the hospital, or not even in the hospital, in the ER or something else, vagal maneuvers are the first thing. So Valsalva maneuver, Valsalva maneuver tends to work best. If you have someone who's laying on their back with their legs up just a little bit, technically you're supposed to move their legs while you're doing it, but it's easier just to say, hey, look, elevate the legs a little bit, laying on your back, try and tighten your belly muscles. You can have someone blow into a syringe, we do sometimes. Carotid massage is the other thing you can do. So a firm massage, 5 to 10 seconds on one side or the other side. Don't do both at the same time. You can check listen for bruits first if you want to do this. But again, if you're going to be doing Valsalva or carotid, if you have the ability to have the person on telemetry or a 12 lead, that would be good also. Adenosine, usually the first line medication we'll use either 6 milligrams, and if that doesn't work, go up to 12 milligrams. Sometimes if you're with like me, I'll do 18 or even 24 milligrams. If someone has a central line, use that if possible because it has such a short half-life, adenosine. You can then give beta blockers or calcium channel blockers if adenosine doesn't work. And even if someone has Wolff Parkinson White known on their baseline EKG, if they're in SVT, you can use those medications. The reason we get concerned is that what you don't want to have happen is have someone who is in SVT, like AVRT is the type of SVT, and they convert to atrial fibrillation, and then we worry about AFib with WPW. You can cardiovert people. So like that patient I described with the atrial tachycardia, he's having ST changes, he's having some chest pain. If you're not able to get him out with adenosine, or you're not able to get him out with a beta blocker or slow him down, like it would be within reason to sedate and cardiovert someone like that. All right, next patient, or 2 patients. So case 4. So we have 2 patients who have the same diagnosis. So on the top is a printout of their telemetry, and the bottom is, and those are 2 leads. The bottom one is a EKG, the telemetry, and then a pulse ox. So my question for you on these two patients, what's the diagnosis? Do we have artifacts? Do we have atrial flutter? Do we have atrial tachycardia? Do we have VT?
All right, votes are coming in a little more slowly. I think as people take time to really look at these strips. So go ahead. Put your nickel down, make your very best guess. And there we go. Okay. Good. All right, I will go ahead and close the poll and share the results.
All right, 50% of you, good work. And the other ones, great job guessing. I love it. I love that you've put your nickel down, as Gabby has said. All right, so these are artifacts. So we'll go back to this. So the key here on the top pair, P-wave QRS complex, P-wave QRS complex as you get on the left side. And then all of a sudden you start to see this noise coming through, and those extra signals are, they are not necessarily regular. They don't look exactly the same. And the rate is the same on the left half versus the right half. So you have not seen a difference in the heart rate. And it's really rare to have someone be in sinus and then go into an arrhythmia and not change the heart rate. And you would be using your calipers to march out your QRS complexes to see something like that. On the bottom one here, you have a pulse ox, and your pulse ox is showing a regular waveform at 75 beats a minute or something like that. And it does have some bumps on it, but if you take a step back and you look at the EKG on the top line, there is a QRS complex that is marching through that. So this is someone who's brushing their teeth, who has a tremor, who's doing whatever it is, and there is a QRS complex marching through with your calipers that you can see. But also it's a discordance between the pulse ox and the EKG, and so you have to try and reconcile that in some way. And the way that you reconcile that is the fact that you have artifact. Now you can ask the patient, like, what were they doing at the time, to help give you an answer, and oftentimes they don't know what it is. But try and use these things like your pulse ox if you have that available. Try and use something like an arterial line, or if you're in the CCU, if they have a Swan catheter in that their pulmonary waveform. Whatever it is, try and use your auxiliary data to help you out, because telemetry artifacts are really common. Now, what I will tell you is we are very lucky at our institution, especially on 5 Northeast. Our teletechs that are on 5 Northeast that watch a bunch of the floors are really good. They're really good. I learned from them. And so they're pretty good about knowing about artifacts. So at least on that floor, 5 Northeast, 6 Northeast, I worry a little bit less about this issue. All right, so sorry, we're gonna get into Y complex tax. So a 35-year-old who has a history of non-ischemic cardiomyopathy, and he has palpitations, and then this is his EKG. So what's the diagnosis on this EKG?
All right, coming in fast and furious this time.
Great, love it.
Okay, ready everyone? We'll go ahead and call it.
Good, yeah, VT. So you can have VT that is barely T, that is barely tachycardia. So here it's 114 beats a minute. You can have a really slow ventricular tachycardia. Now you may say, well, how do you know that this is ventricular tachycardia and not sinus tach? So the first thing is you're trying to look for P waves, right? So we already said it's a regular Y complex tachycardia. It helped put it in a one of our boxes for us, one of our quadrants. But then you're going to look for P waves. And so I have helped you out here and given arrows to show where the P waves are buried. And in this case, lead 2 is going to be your easiest spot to see it. but you have a P wave that's underneath one arrow, another P wave coming through, and you can use your calipers to march out your P waves in this situation. So there is VA dissociation or AV dissociation, and there is more QRS complexes than P waves, which is going to make you think that this is ventricular tachycardia. Other things on this EKG is that there is negative concordance. So when you look at all of your QRS complexes and just leads V1 to V6, the precordial leads, they are all negative. If you see them all negative, that makes it more likely that this is VT. Same thing is if they are all positive, it makes it more likely that it's VT. But if there's a transition, if there are some leads that are negative and then some leads that are positive, it doesn't help you as much. So all negative or all positive is going to help put it more towards the VT side of things. If AVR is positive, also it makes it a little bit more likely VT is positive. Actually, that it's VT, it's not quite as good a criteria, but it does make it a little bit more likely also if AVR is positive. The other thing is substrate. So if you have someone who's got a low ejection fraction or who's got a cardiomyopathy, VT is going to be in your thoughts. If it's not in your thoughts, make it in your thoughts. It doesn't mean that they can't have flutter also, because that would be common. And then the other thing is, knowing what their baseline EKG looks like. So if their baseline EKG has a QRS that is narrow and then it's wide during their tachycardia, you're going to be thinking it's more likely VT. But if they have, let's say, a right bundle branch block on their baseline ECG, and then they go into a tachycardia and they have the same right bundle branch block, you're going to be thinking more likely it's some type of SVT or flutter or sinus tach or something like that. Sometimes you'll see something like this, which is a fusion beat. Fusion beat is where you have a QRS that is sort of a mixture of a sinus beat that's coming in at the same time you have VT. So this beat that I highlight for you there is a little bit narrower than the rest, and that's because that's a fusion beat of sinus and VT at the same time. Sometimes you will have VT that goes really fast, right? This is, I don't even know how, like 230 beats a minute or so. Maybe. So this is VT going really fast, and we have an EKG of it. So thank you to whoever got it. And this is another example of that concordance, that precordial concordance. All the QRS complexes are positive here in V1 through V6. So this would be another one that goes along with this being VT. You will sometimes see people, and we don't see this quite as often now as we used to, probably because we've ablated a lot of these people, but that have paroxysms of VT that are from the right ventricular outflow tract or any part of the outflow tract, but we'll have these repetitive bursts of VT. So they have a precordial transition, but it's this left bundle branch block pattern that's positive to the inferior leads. It's a little bit sort of diagnostic for this this type of VT. So what do you do if someone presents with VT? So if they are hemodynamically unstable, shock them and do your ACLS algorithm. If they're stable, please don't shock them. I was on a phone call like 5 years ago with a fellow, and the fellow was like, this person's in VT. I think we need to shock them. And then in the background, you hear the patient go, wait, you're going to do what now? So please make sure if someone is stable and able to talk to you that you're not just going to shock them. And again, don't use your hemodynamics to diagnose. Their blood pressure does not tell you what the rhythm is. And if you have someone who's in a Y complex tachycardia that's VT, call us. Give amiodarone if you have someone in a stable rhythm is our most common thing we'll use. Sometimes we'll use lidocaine, especially if it's in the setting of concerns of ischemia, but we'll go with both for people who are in a VT storm of amio and lidocaine. Depending on what their ejection fraction is and what their heart failure status is, we might be giving them a beta blocker also, and there's some suggestion maybe propranolol is better than metoprolol in this situation. If you have someone who's in really bad dire straits, we'll use an Impella or a balloon pump or even ECMO for somebody who's in VT storm. Sometimes we have to intubate and paralyze patients to try and really minimize all of their catechols, which could be driving this. So any of those things, but if you're getting to the point where you're talking about intubating, paralyzing, and Impella, I hope that you have the CCU service involved in some way. All right, PVCs. You are going to be called about PVCs. The question again is, do you need to do anything about these patients? All right, most times, if you have someone who's going into frequent PVCs, you don't need to do something if they're asymptomatic. You just say, okay, like MD notified. However, if you have someone who is symptomatic, you can give a beta blocker, you can give a calcium channel blocker. Are you going to check labs in the middle of the night? Yeah, I mean, like sometimes you'll do it just because it makes it so that you don't get called a second time about it. But most times their labs are going to be normal. If you have someone on diuretics, maybe you want to know what their potassium is because the hypokalemia may be exacerbating these. So sure, you can check, BMP to see what their potassium is, but it's going to end up being normal. Honestly, half the time you just want to turn off telemetry so you don't get called about it. And that may be a reasonable option depending on whatever the reason is that they're on telemetry. So most times you don't have to worry about PVCs. All right, if you have someone who's got polymorphic VT, you got to do something about it. So again, I don't know why I have this 12 lead of polymorphic VT and why the person wasn't getting chest compressions in the middle of this. But here it is. That's what polymorphic VT looks like on a 12 lead. And that's a really ugly looking polymorphic VT in a guy who had long QT. So someone like this, you want to shock them and do your ACLS algorithm. You'll give magnesium for something like this. And you want to get an EKG when they're not in VT. That's really important because that's going to help guide what your management is. If you see a prolonged QT interval, that's going to tell you one thing. If you see ST elevations or ST depressions, that's going to tell you another thing. Because your big differential when you have someone who's in polymorphic VT is going to be, is it ischemia or heart failure related, or cardiomyopathy related, or is this torsade related to long QT or Brugada syndrome, which we don't see super frequently. You're going to be calling us, hopefully, in some way. And if you have someone who you think it's ischemia driven, then you give them a beta blocker. If you have someone who is a genetic channelopathy or a drug-induced long QT syndrome, you're actually going to be giving them isoproternol, which is a beta agonist. For some of those people, you might actually be even putting in a temporary pacemaker to try and get their heart rate up, which can help suppress a polymorphic VT storm. Again, if you're worried about ischemia, then you would do an ischemia evaluation in some way. And just a little plug, if you have anybody who has long QT syndrome and you're worried about them, or if you see their QT interval is getting a little bit long for whatever reason when they're in the hospital, because maybe they're on a QT prolonging drug, you want to avoid other QT prolonging drugs. There is a website and an app called Credible Meds, credible.meds.org, and the app is Credible Meds. You can look up QT or drugs that prolong the QT interval. For me, I use this list all the time, but that's because I follow patients with long QT syndrome. But credible.meds.org is a great website or an app that can let you look up medications that affect the QT interval. All right, VF. So I actually have more EKGs of VF than I have of polymorphic VT, and that's because of LVAD patients. So if you have a patient who's got a ventricular assist device, an LVAD, and if they don't have an ICD in place, they may go into VF and not even know it, or they may just have minimal symptoms associated with this, and you can get a 12 lead. So if you have someone who's in VF, shock the patient unless they have an LVAD, do chest compressions, do ACLS drugs, don't bother getting an EKG, please. Please save the person's life. All right, bradycardia is in our last 15 minutes. So sinus bradycardia. So in this situation, you have someone who has a slow heart rate. There is one P wave for every QRS complex. Here it is, they have a slow heart rate in this example. I'm not going to get into first degree AV block because that's AV delay and not really block. Here's an example of Wenckebach or type 1 second degree AV block. With this, you have a PR interval that's short, longer, 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 and then drops and then short again. When I'm looking at something like this, I am not looking at every single heartbeat, and I am not measuring the PR interval on every single heartbeat. I go for the money. So I go for the beat just before the drop beat, and I go for the beat just after the drop beat, the return beat. And that's where you're going to see your greatest difference. So there's no point in sitting there measuring every single one. Measure the one which has a really long PR interval right before the drop beat here of, 600 milliseconds approximately. And then the one on the return beat, which is more like 200 milliseconds. If you're going to be sitting there trying to figure out is it type 1, Mobitz 1, type 1, Mobitz 2, or type 2, that's where you're going to get your answer. If you see that the first return beat has a prolonged PR interval, like over 200 milliseconds, it makes it a little bit longer that it's going to be Wenckebach because it's suggesting that there's AV node disease. Versus here's an example of type 2. And here you have PR, it's the same, drop, PR, same. Here, this person has a right bundle branch block. The middle EKG here is lead V1, and you can see that gravity or bunny or pattern. The QRS is wide. It's an RS R prime, with the R prime being bigger than the R. Here, because they have a baseline right bundle, it makes you think it's a little bit more likely that the disease is in the His-Purkinje system, and that's more likely to be type 2. So you can try and help that or use that to guide. A lot of the time, you'll get an example like this, which is they have 2-to-1 heart block. And here, it's a little bit more challenging to tell, all right, is this Mobitz 1 or is this Mobitz 2? And you can't tell. So you need to try and find times where they have 2 beats in a row that conduct to help figure out is the PR interval lengthening or not. So in this situation, you can't tell what they have. Complete heart block. So here you have, first off, just the gestalt, eyeballing it, looking at it, and you're like, yeah, that's not normal. Heart rate is slow. There are more P waves than QRS complexes. There's no relationship between the P waves and QRS complexes. Although this is always one of my favorite ECGs as an electrophysiologist. And the reason is that you have, if we look, let's say in the middle QRS complex here, you have a PR, and it's really short, so it doesn't conduct here because the QRS complexes are marching through. You have a P wave that doesn't conduct. You have a QRS complex, and then you have a negative P wave here. So even though there is no conduction going from the atria to the ventricles, you actually have conduction going from the ventricles back up to the atrium. And so you have a retrograde P wave. And so to me, like, I love this ECG because the heart is really cool. And you have no conduction going forwards, but you have conduction that's still able to go backwards. We use a fancy word called anisotropic conduction for something like that. But someone like this, you have complete heart block because there's more P waves than QRS complexes. The QRSs are slow, and there's no relationship between the P waves and the QRS complexes. Here is another example of complete heart block. So this is someone who is in atrial fibrillation, and their heart rate is slow. It's not super slow. It's, I don't know, probably 40-ish beats a minute, maybe 50-ish beats a minute. But here the person is in AFib, and their QRS complexes are regular. So AFib should be irregular. So anytime you see regularized AFib, you should be thinking to yourself, all right, is this person in heart block? And the two situations that we see this in a hospitalized setting, I guess 3 is someone who presents with heart block, but the other situations would be someone who's post-cardiac surgery. So you have someone who's got AFib, they have cardiac surgery, and then they are, their AV node got dinged in some way and damaged, and so they have heart block from that. The other situation where you see regularized AFib is digoxin toxicity. So dig toxicity gives you regularized AFib. Dig toxicity can give you pretty much every arrhythmia, but regularized AFib is one of the classic things that you see for digoxin toxicity. All right, so how do you manage bradycardia? So usually what we're talking about is a heart rate less than 40. It's going to be atypical to have someone who's got symptoms. Let's say in the 50s would be really atypical. But even in the 40s, it's a gray zone. Sometimes you'll get people who are symptomatic, but usually we're talking about heart rates less than 40. And just like everything else, the question is the patient symptomatic? So are they having mental status changes, hypotension, angina, shock, heart failure? Are they dizzy? Are they just feeling bad? And is it acute or is it chronic? So I saw a woman in clinic the other day who's a triathlete, and her resting heart rate is 41 beats a minute. All right, like, we're not concerned about her. It's a physiologic bradycardia. But is it someone who did have a heart rate of 80 and now all of a sudden they've gone abruptly to 40? All right, now you're going to be more worried about someone like that. And are they sleeping? Do they have sleep apnea? You will have patients who will develop complete heart block while they are sleeping, and you do not need to worry about them. So not everyone with bradycardia needs acute treatment if they're stable, even with complete heart block, especially if they're sleeping. This happens all the time, that someone will go bradycardic, will have prolonged pauses while they're sleeping, and then everyone comes rushing in and wakes up the patient to say, are you okay? Now, they were asleep, all right? And they say, what was going on? You do not have to worry about someone like that. If you have someone who presents with complete heart block, let's say, and they come to the ER with complete heart block, and they have a narrow QRS complex, it's a junctional rhythm. You do not even have to necessarily put a temporary wire in that person. You can admit them and then wait for us to put in a pacemaker the next day. If it's a wide QRS complex escape rhythm, that's a different story, and you'll probably want to do a temp wire for them. But honestly, what you're going to be doing is you're going to be calling us. So in general, the management is if it's an acute issue and it's a code type setting, you're going to be doing transcutaneous pacing. But please sedate the patient because transcutaneous pacing hurts. And my one plea to you is don't leave pacer pads on a patient, quote, just to be safe. I did a research project with a former intern where we tried to look at how often those pads were used, and the answer was pretty much never. And then they just get itchy and irritable to the patient, and then the patient becomes irritable. So don't just leave the pads on a patient just to be safe. Atropine, you can do that, but if you have someone who's got Mobitz 2 heart block, it can actually make it worse because they get sinus tachycardia in their AV node, or his Purkinje doesn't like it. If you have someone who's got a cardiac transplant, it can also make things worse. And the same thing of don't say atropine at the bedside because it's never used when you say atropine at the bedside, and some floors don't allow you to keep code medications in the room. So don't say that because it's never used. You can give dopamine, you can use epinephrine, you can give glucagon if someone's had a beta blocker overdose is the cause of it, and then transvenous pacing, but you're going to be calling us in that situation. All right, so in conclusion, in our last 5 minutes, you're going to be called frequently about arrhythmias. You're going to be called frequently about AFib. You're going to be called occasionally about SVT. You'll be called frequently about PVCs. Get an EKG, look at the tele yourself. If it's tachycardia, again, please don't use hemodynamics to diagnose your arrhythmia. Figure out, is it wide or narrow? Is it regular or irregular? And then that will help give you your differential of what the rhythm is. For almost every tachycardia, beta blockers or calcium channel blockers, you can use those. You might use adenosine if you think it's SVT or if you don't know what it is. Amiodarone is your medication you're going to use if you're going to try and convert someone, especially if it's an AFib. But Cardiovert, and whether it's acutely, if it's if someone hemodynamically is unstable, or whether it's within 24 to 48 hours, or if it's over 48 hours and they're on anticoagulation, you can do it that way. And if it's bradycardia, think about where is the level of block. If it's in the AV node, you're less concerned about it. If it's below the AV node, then you're going to be more concerned about it. And are they symptomatic, which is going to be the #1 thing that's going to help you determine how to manage the arrhythmia. Are they sleeping? And if they're sleeping, please don't worry about brady arrhythmias. And then again, if you're really concerned if they're unstable, then you'll be calling us in cardiology or an EP for doing transvenous pacing. So thank you. If you ever have interesting ECGs or if you have ECG questions, please feel free to email me. I love ECGs. I think they're fascinating and fun, and you can learn so much. So please send on interesting ones to me. So thanks. If there's any questions, I'm open to taking it. If not, I'll give you your few minutes back to go pre-round.
Thank you so much, Jordan. So appreciate hearing from you every year. And for the interns, I hope this was as high yield for you as it is for me every year. You will see in the chat that I've posted links for both the attendance and survey. So if you weren't able, if you did the QR code and I just told you that you already had registered an answer or whatever, don't worry about it, we've got you. But please do scroll up, do the evaluation. We really value your feedback and input. That helps us determine how to shift our schedule every year, who to invite back, which lectures to continue, and what we might be missing. So again, thank you so much. I'll let Jordan take any questions. And otherwise, I'll see you all next week, same time, same place.
All right. Thanks, then, everyone.
All right. Looking like everyone's getting an error. So maybe Javel sent me the wrong link. So I apologize. So what I will do is ask Javel to send the evaluation for this talk to the R1 listserv. So please be on the lookout for it. And I will include it in my follow-up email with Dr. Prutkin's slides and the link to the recording to incentivize you to take 2 minutes to fill out our survey. Cool. Thanks, everyone.
Thank you.
Thanks, Jordan. See you
Have a good
later.
day, everyone.